Yes.
Professor Collins, I've now got, I'm going to ask you a handful of questions from the call participants. First of all, did you ever, Professor Bloom died 4 years before you arrived in Cardiff. Did you ever meet him and speak to him?
No, I never met or spoke to Professor Bloom.
You exhibited some of the treatment protocols that were in existence during Professor Bloom's time, and you've exhibited those to your witness statement. Do you know where those treatment protocols were found?
Yes, they were in a file. There was an arch lever file that was in the Haemophilia Centre when I looked through all the documents to see what would be of relevance to the inquiry.
And you mentioned that when you joined the Haemophilia Centre, there was still some of Professor Bloom's documents in his room, which then became your room. What documents had he left?
Well, those are the documents that I've just described.
So there was the treatment protocols.
Well, there were lots of documents there. There were various letters that I've submitted to the inquiry about the use of different concentrates. There was, importantly, I think there was a whole 2 arch lever files of reports to solicitors about individual people who had contracted HIV, which again I've declared to the inquiry. They're about individuals, of course. And then there were lots of documents about day-to-day management of things that I didn't think had any relevance to the inquiry. So my understanding, because I didn't make the submission to the inquiry on behalf of Cardiff and Vale UHB. That was made by the people. My understanding was that they sent all of it, but I don't know if that's definitely true.
Well, we can make inquiries about that. The inquiry will know. Do you know whether Professor Bloom held any files relating either to the centre or to patients at his home?
I don't know. I have heard, I think it was a radio programme on BBC Wales to suggest that might have been the case, but I have no knowledge as to whether that's true or not.
So a couple of questions then about links with pharmaceutical companies. I asked you some questions about the funding provided by pharmaceutical companies in 2000, so 5 years before the national tender process came into place. What steps at that time, so before the national tender process was in existence, so around 2000 or before, what steps were taken, if any, at the centre to ensure that the funding received by pharmaceutical companies of the centre did not influence product selection?
So there were 3 pharmaceutical companies involved, and there were 3 brands of recombinant factor VIII. They all donated roughly the same amount of money. So it wasn't as if one was more influential than the others. My opinion at the time was that all 3 of those recombinant factor VIII products were equally safe and as efficacious. I think they all were good quality products and all could have been used. I can't remember exactly what products we were using at that time. I think we were probably using all three. That's the best I can do, I'm afraid, on that.
Do you think that does the fact that the national tender system that's currently in place, does the fact that you have complete freedom to prescribe from any of the medications on the list, on the approved list, or purchased products, mean that there is still scope, in your view, for there to be for donations from or support from pharmaceutical companies to influence prescribing policy? So in other words, the fact that there is a tender system in place, is there not still scope for funding from pharmaceutical companies to influence prescribing policy at the centre?
I think there is the potential risk that there would be influence, yes. I think that this is an issue that affects many areas of healthcare and many areas of public life. I do not think that the prescribing in Cardiff, or now that we are involved in treating people in Swansea, I do not think that it has ever influenced our decisions with regard to which products to use.
So a couple of questions on the research database, the UK HCDO research database. Given the process that you described of getting informed consent from patients and the fact that you'd actually got quite far through the process in Cardiff,
yeah.
When you were when the UK HCDO was advised to stop that process, is it right to say that it would have been practical, at least from Cardiff, would it be practical to obtain informed consent from patients to the use of their data for research purposes?
It was definitely practical to obtain written informed consent from the very large majority of patients. The database holds quite a lot of information on people who are no longer seen in any haemophilia centre. They're essentially lost to follow-up. And Cardiff has some people in that category. Very difficult to reach those people. I think that we could have taken written informed consent from 90 to 95% of people, and that was completely practical. I think there was always going to be a small group that would be very hard to reach. And as I said earlier, my personal preference would have been to be allowed to have carried on doing that had the confidential advisory group not changed their advice to us.
And why can't the data that's held in the research registry part of the database, why can't that data be held anonymously so as to protect patients being identified when research is when that data is being used for research purposes?
There aren't two registries, there's one registry, and the one registry is used for the direct patient care, for the research, and for the public health planning. When the data is used for research purposes, it gets anonymised, or perhaps better, pseudo-anonymised, so that the analysis is based on pseudo-anonymised data, but the database itself doesn't change, it's always there. So the fields that identify people are hidden when the analyses are done.
Moving on to a new topic now, what role has the Welsh CMO, Chief Medical Officer, played in the management and oversight of the Haemophilia Centre since you've been there?
I have, well, with the Chief Medical Officer, I can't remember any direct interaction, but with the Deputy Chief Medical Officer, Dr. Chris Jones, he of course has had interaction with the Haemophilia Centre, and he chaired the ministerial review in 2011, and he chaired a follow-up review. I think it was around about 2015, particularly looking to see whether the recommendations have been implemented, and of course at that time the question of why the hepatologist hadn't been appointed was revisited. So certainly the Deputy Chief Medical Officer has had quite a lot of interaction with regard to the inherited bleeding disorder service with that review.
And then lastly, when meetings were held between clinician groups in the Department of Health, how was the Welsh Government represented from 1996 onwards? Are you able to answer that question?
I can't answer that question. I don't think I have any knowledge. These are meetings between the Department of Health in Wales and the Department of Health in England. Is that the question?
I think no, between clinician groups in Wales and the Department of Health in Wales is what I imagine.
I mean, apart from the ministerial review, I don't remember any really significant interactions. There were some letters and information about things like Skipton Fund and that sort of thing, but I didn't have any discussions with any of the politicians with regard to that. So I don't remember anything directly, I'm afraid.
So those were the questions from the core participants.
Yes, thank you. Well, I have one or two of my own. Can I just pick up on that last question that you were asked? And link it to what you were saying earlier about the role of the transfusion service in Wales, which looked after the supply to you of products. At the time you were talking about that, the thought went through my mind, suppose a new virus happened to be identified in blood. Now, I appreciate that now blood products tend to be recombinant by and large, but some still aren't. So it's a possible risk to blood products. It's certainly a risk to the blood supply more generally. You said that you would expect to be told or learn about possible hazards in blood by being told by the Blood Transfusion Service or through UKHCDO. So the question then arises how they know. And they presumably will know in the usual way that some doctor or some surveillance authority in some country, in some part of the world, identifies that something has happened. Something has happened that deserves to be reported, and so it's reported, and then somebody writes about it in a peer-reviewed journal, and other people begin to take notice. And fortunately, in the modern world, with the internet and so on, news can spread quite rapidly, and probably, one hopes, faster than the virus. But would that not come to your notice in that way? Would it come to your notice you'd expect through UKHCDO or the Transfusion Service? And the reason I link that with the relations with the Welsh Government relates to this, that part of the landscape that I'm looking at in this inquiry involves the DHSS. Now that largely the evidence will relate to what happened in London. But of course healthcare is now a devolved issue more strictly than it ever was. And so the Welsh Government has the same role, perhaps, it might be thought, in respect of what happens in Welsh hospitals as the DHSS had in those days across most of the UK. And plainly, the medical division of the DHSS were kept informed and had their own views and about what was happening, what the risks were, and so on. So how do you see it working if a new virus is identified somewhere which has a threat to blood products or blood supplies, or for that matter, not necessarily a virus, something like a prion?
Well, I think for the blood supply, for example, in red cells, platelets, FFP, cryoprecipitate, that is produced by the Welsh Blood Service, I would expect that they would be the first to become aware and alert and make sure that was known. I would have thought that immediately they would be in discussion with the Welsh Assembly Government about a threat of that severity, but I don't personally know what committees or what groups would do that because it's not part of my remit. What I was saying about more likely to be hearing things from UKHCDO would be that if there was a problem with a concentrate, I would expect that would be known in the haemophilia world and that would be picked up by one of my colleagues, and I would be more likely to, very rapidly hear about it from there. So let's say, for example, variant CJD. I heard about it through Professor Ludlam sending me a letter in 1977, even though, as I've explained, that at that time the suggestion was that this wasn't anything to be concerned about and that we weren't supposed to be telling patients. So I think that that is from the point of view of the concentrates. I would have thought it might well be that UKHCDO or a member of that UKHCDO might hear first. There's a reporting system within Europe called UHAS, which is run by Professor Macris at Sheffield, and that looks at risks of blood products, both recombinant and plasma-derived. It may well be that information would come through that reporting system early and quickly. And so I think it's difficult to know exactly where the information is most likely to come from in respect of if there is a completely new, out of the blue threat to the blood supply. I would have hoped to receive information from multiple sources very rapidly.
Would one of those sources be the database?
It's possibly it will be the database, though the database is, of course, reporting retrospectively, and so if a new treatment was causing serious side effects, the database may not pick that up for 3 or 4, 5, 6 months after these events started happening. But there is an example within the database of one of the recombinant factor VIII concentrates was thought to be being associated with more inhibitors than other recombinant factor VIII concentrates. And the database very quickly looked at the information held in the database and was able to confirm that did look like it was the case. And that led to people in the UK using different concentrates. So that did happen quite quickly. So the database does have the ability to look at this sort of thing, but it is, as I say, retrospective.
I mean, obviously a lot may depend upon the precise data which goes into the database in respect of what are at first anecdotal reports of reaction or illness. Does anyone keep a a close weather eye on the database, or does it come into play only when it's responding to the worries of others?
No, there is a reporting system. So every month, the database sends an email to every haemophilia centre saying, do you have any adverse events to report? And names certain adverse events like thrombotic events, infections, I can't remember the other neurological events because of, might we start picking up variant CJD issues? So it says, it specifically asks every month, have you had any of these events? Our data manager in Cardiff emails all the consultants in Cardiff and says, have you seen any events? And if we have, they get reported. The reports then are reviewed by the director of the database, who's Dr. Hay at the moment, Professor Hay at the moment, but also there is a working party called the Comorbidity Working Party. And if there's any serious adverse event, like, for example, a thrombosis, or someone's been given a treatment and they've had a heart attack or something, that committee will review the circumstances of that event, and they will review it with the clinician who's reporting the event. So there'll be some kind of, Zoom meeting, and the clinician will report it. And that group will then come to the conclusion whether they think that the event is likely to be causally related to the product or not. They will then report that on to the manufacturer and to the authorities to say that this adverse event has been reported. So, and of course, if there's a serious event as well, then the protocol is that UKHCDO will email the whole membership to say a person has been treated with treatment X and they developed a heart attack immediately after. You should be aware that this has happened, and that would be the process that has been put in place to do that. So the events don't sort of disappear into a black hole, as it were. There is some attempt to scrutinise the severity and the likelihood of causality, and then to communicate that if necessary.
So what you're describing... sorry.
Sorry, I was going to say that's a relatively recent thing that we've set up over the last few years.
From the way you're describing that is something that has happened.
It has happened, yes. So events have happened, and clinicians have discussed with the group who's overseeing the events, and decisions have been come to as to whether they think the event is related to the product or not, and that information has then been disseminated to the membership. That has happened, yes.
What information do you know has been given to the patient about the fact that their data or their event has been reported in this way?
I think that, well, I don't know. I think that would be down to the doctor looking after them in the centre that has submitted the information. Clearly, the patient will know that the event has happened because it's happened to them, and in addition to reporting to UKHCDO, you have a duty to report through the yellow card system as well. So if product X causes someone to have a heart attack, you have a duty to report through that yellow card system completely separately. So there are multiple ways forward. I think it would be up to the individual clinician to inform the patient that report has gone in.
If you happen to be the individual clinician, what would you think you would do?
I think that for a serious adverse event that we were reporting, we would I think we probably would talk to the patient now. I think, to be completely honest, before this inquiry started, I probably may not have done. I have been made to reflect on keeping people better informed of what is being done with their information, and I think that's something that UKHCDO as a whole has been reflecting on.
The reason I ask, it's probably obvious, is that there have been a number of comments made to the inquiry that the individuals who have been told they've had HIV or hepatitis C, or for that matter hepatitis B, weren't told, though it was hypothesized that it was the case, where they got it from. And they weren't told that they had it from infected blood. So I think you may well be right that they are expressing an interest in knowing of the source if it is known or hypothesized. And that's I think the outcome of your own ruminations from what you've been saying.
Yes, I mean I think that is the case. Yes. I think there is also, we need to think that haemophilia doctors looking after people with bleeding disorders now, many of them are young consultants who may not be aware what people have been told in the past, and so may not be aware that people haven't had all the information that they may reasonably expect. And I think that is something again that we are considering as a group, how that should be addressed.
That leads me on to something I was going to ask actually a bit later in the questions which I have for you. But you may recall that when the inquiry was in Cardiff at the Royal College of Music, you and I had the odd conversation, and in one of them you were saying how reacting to the evidence which you've been given, that you hoped or wanted some of your staff, or your juniors, to come and hear what was being said. Did that happen?
Yes, so a number of members of staff were at the hearings in Cardiff, there for a number of reasons, both to hear the testimony of the people giving evidence, because some of these people, the evidence was about, had died long before the staff were part of the Haemophilia Centre, and even before I was at the Haemophilia Centre, and I thought it was very important that people knew and understood what had happened, because I think it is so important in trying to provide a service for this group of people. But they were also there to try and lend, as it were, moral support to the people giving evidence, because many of the people giving evidence the staff knew very well, and they knew that it was a very difficult it was a very difficult situation for these people to tell their story, and we thought it was important that members of staff were there to help people. We discussed this in advance with Haemophilia Wales to make sure that they thought that was the right thing to do, and they said that they did. Some members of staff who had long left the Haemophilia Centre or who had retired came to the oral evidence in Cardiff specifically, and I'm thinking here of some of the social workers who'd retired, specifically to help give support to people who had been giving their evidence.
And insofar as younger staff may have learned something, what messages, what lessons do you think they took away from listening to the evidence of those who gave it, in what you say was courageous evidence to give?
I think there are a lot of things that have come through, but I think one of the most important is that although these events may have been in the 1970s and 1980s, before some of the members of staff were even born, they are still very important and resonant to the people that they were affected with, both the individuals and their families. And I think that we mustn't think about this as all being events in the past. These are events now. People are still living with the events. So it's not a historic thing that we're looking at. It's ongoing, and it will echo down the generations. I'm sure of it. That, as I've explained, people who have children with haemophilia now may have lost their father, and it will continue to be very important for a very long time.
In one sense, I suppose you came to Cardiff after what may be seen by some as a question of history, although you see the ripples extending down into the future. You have some similarities in your position looking back as we do at the inquiry, looking back on what has happened without knowing from first hand what was happening. You have this advantage that you have taken over the reins and are being involved in the treatment of those who suffered and and related to their families and carers and so on an ongoing basis. So you have a lot of involvement in that sense. What lessons would you learn for the future that we might all use to ensure that the ripples are as small as they have to be?
Well, I think the fact that we are having this inquiry is a major part of that process. Ever since I started in Cardiff, people have been coming to me saying that they think that there needs to be a full, open, transparent inquiry into what happened so as to understand the process. And I think most of the people I talk to in Cardiff, it's that they want to understand clearly and fully what happened and not have this residual concern that things aren't being uncovered and aren't being said. So I think that will be absolutely crucial to how the events are, as you say, ripple down the generations, is to whether it can, the outcomes of this inquiry can resolve the questions that the patient group are asking. I think that's absolutely key to what happens. I think that I've always felt that we needed this sort of inquiry. When I went to Cardiff, I hadn't considered that, but talking to the patient group from a very early on, they persuaded me that it was the only way that things would move forward. And I think that is very important, that we have a clear understanding of what happened and, if as far as possible, why it happened.
And perhaps do what it can to ensure that something like it never happens again.
Well, I think very important that we minimise the chances of anything like this happening again. I think it's you never know what's round the corner, and it is very important that everything that can possibly be done to prevent further serious complications of treatment that are being given to people with bleeding disorders, that everything is done to prevent that. And I'm not just thinking about infectious disease. but complications of other treatments. We have to have do as much as we possibly can to prevent further problems.
Changing the topic just a little, though it's got a link to what we've just been discussing. It always struck me listening to the evidence that we've been having as to the past, that being a congenital disease or condition, I'm sorry, shouldn't call it disease, condition. Haemophilia is always going to be recognizable most often in very young children, and that may be with parents who, because of the nature of the genetics involved, may not themselves have any familial experience of haemophilia. And so they're on their own, and they're lost a little bit with a child who has a condition they don't perhaps fully understand. And the child needs to come to terms with it too. So why wasn't a pediatrician or someone with an RCPH, the Royal College of Pediatrics and Child Health qualification involved? Well, you have in your Cardiff Centre, from what you were describing, thoroughly involved pediatrics. You have a consultant who is primarily focused on children. You're plainly equipped with play specialists to assist the child, with particular nurses who have pediatric experience, which reassures me that at least in one centre that has been the model. How common is it across the whole country, by which I mean the UK?
Most children in the UK are looked after in paediatric haemophilia centres. So centres like Great Ormond Street, for example, would only look after children. Other centres where both adults and children are looked after, for example, in Oxford, they have a paediatric haemophilia consultant who looks after the children. So I think it's the case now that there is certainly a recognition that children should be looked after people who specialise, who are paediatricians who specialise in looking after children with bleeding disorders. I think that would be the general standard of care. Again, another example would be Bristol. It has a combined adult and paediatric centre, but the paediatric centre essentially stands alone with paediatric haematologists and haemophilia doctors and nurses looking after their patients. And there are examples all around the country. Glasgow would be another good example of the two centres, adults and children. I think it is the case that children are looked after by paediatric specialists, certainly the severely affected children.
Well, that's true, of course, in the bigger centres. What about the centres and the associate centres? Do they have any such involvement, or do they simply refer children on to the reference centre or the care centre?
I think, well, it's difficult for me to comment outside of South Wales. In South Wales, children are looked after through their treatment is coordinated by Cardiff through the Comprehensive Care Centre, but the treatment might be delivered through a clinic in Swansea or Abergavenny, where one of us goes out and tries and sees the person more locally. Our nurses will travel all the way out to West Wales, 100 miles or more, to visit patients in their home, to help with training with venous access and this sort of thing. So I think that there is certainly a significant focus on trying to make sure that children are well looked after. In addition, in the Cardiff Centre, we have a general paediatrician who comes and does joint clinics with us. So she's not a haemophilia doctor, but she's a general paediatrician. So she comes and does the joint clinic with one of the haemophilia doctors, so that if the children or the parents bring up a non-haemophilia related issue, then we have the expertise to address that.
And the only other thing that I wanted to ask you was when you have been discussing with patients what treatment they might prefer, whether they want to stay on what they've had, go on to recombinant, if not, what sort of recombinant, these sorts of discussions. How long, roughly, do those discussions take? You said it was a process, and plainly that must be right and sensible, but roughly how long the initial conversations and how long overall do you think you might end up discussing in the average case?
In the average case, if it's a question of changing medication, I would say on average it would be 10 minutes on a first consultation, and then 10 minutes sometime later once the person has thought about it. In addition, the nurses will have separate conversations about the issues, and sometimes these issues will go on for many months as people consider whether they want to change treatment or not. So I would say it's roughly that sort of time. You see, but there are different. So changing from one standard half-life factor rate to another standard half-life factor rate is not a huge jump, because it's a very similar treatment. But changing from, say, for example, factor 8 to emicizumab, that's a very big change that will almost certainly require multiple conversations to understand the implications of that change and whether people want to go ahead and do that. Partly because it's such a new treatment, the consequences of receiving the new treatment may not all be known, and there may be consequences of receiving that treatment that we are not currently aware of. And so some people see the advantages of once a week subcutaneous, but others see the kind of the reassurance of being on the treatment they've been on for 20 years, and why do they want to change?
That's all that I have to ask. Scott.
So one question has arisen out of a response that Professor Collins gave to a question asked by you, and it's this. Professor Collins, could you explain what the yellow card system is and how it works?
Well, if a adverse event, a side effect relating to a drug occurs, then the clinician will complete what used to be called a yellow card. It's now online. You go through a website and you put in the information related to that adverse event, so that if a number of different clinicians are saying the same thing, then the regulators will note that very early, and to be able to take action if appropriate.
So the online system is run by whom?
I'm not sure I can answer that, I'm afraid. Okay. I don't want to give an inaccurate answer. But it's an official system. It's not, it is an official system. But I don't say which agency, I'm afraid, is in charge of running it.
Thank you. Professor, is there anything that you would like to say?
So I would like to say a few words, particularly about the extraordinary group of people that have attended the haemophilia centres in South Wales over the last 24 years. And these are people that I've come to know very well. They were absolutely central to the campaign that led to this public inquiry, and they battled at times against what must have seemed enormous obstacles. But they never lost focus in that, and that was clear from the moment I first came to Cardiff. It is, I think, a great sadness that many of these people have not lived to see their work achieve the outcome that they wanted, and particularly that they've not been able to hear the evidence and that they're not going to be able to hear the outcome of the inquiry. Of particular note from the local patient group, I would say that establishing the Birchgrove group was an outstanding and defining achievement, and I think it's one that's had significant influence over very many years. I've learnt an enormous amount from talking with this group of people, and I have to say I'm very proud to be able to be part of their lives. I think it's very important when we're thinking about the local grouping in South Wales, is that despite the huge challenges and the grief that has often been associated with their individual stories, the local patient group has always worked very closely and very constructively with the Haemophilia Centre to improve care for people with bleeding disorders across the whole of Wales. Some of their notable achievements in enhancing care have been that they were instrumental in Wales becoming the first country in the world to establish recombinant for all. They campaigned for the new standalone Haemophilia Centre in Cardiff. They greatly enhanced physiotherapy across all of Wales, and they established the psychology service dedicated to people with bleeding disorders. They also were instrumental in improving the hepatology service. These achievements would not have been possible without the tireless work of Haemophilia Wales, and I think it's of great credit to them that these have been achieved. However, the most important thing that I want to say is that the staff working at all the haemophilia centres in South Wales are acutely aware of the suffering that the treatment with infected blood has caused. Many people have died long before their time, and they are all greatly missed. People and their families have had to live with the appalling consequences of this tragedy, and they continue to do so. I am sorry that these patients and their families, who I and my colleagues have had the privilege to care for, have had to experience the pain and suffering caused by these events. Thank you.
Well, thank you very much. I have to thank you for a number of things. Not least, I know that you would have wanted to be here in person to say what you've just said, as well as give your evidence. And I'm very grateful to you for being prepared to change your arrangements at short notice because of the way in which the timetabling had to be worked out in the light of the current virus and its restrictions. So thank you for being prepared to do that. But thank you also for giving us the view of somebody who was right at pretty much at the centre in your involvement in the national committees you've spoken about, UKH, CDO and Cardiff, of what life as a haemophilia consultant and director has been like in the last 20-odd years, and in particular all the challenges that you've faced and the challenges that you've had to experience following on from the tragedy, as you call it, which you've just described. I don't need to repeat it, it's clear. And for giving your evidence in such a clear, direct and helpful way. So thank you very much indeed.
Thank you for the opportunity.
So we're not sitting next week.
No.
And then the following week, on the Tuesday and Wednesday, the 26th and the 27th, is going to be the Medical Ethics Group panel.
Yes, so that will be a panel presentation of the sort that those of you who were here would have seen before when we had our previous expert group. So this, of course, will be online, which will be a new online experience for us, but we shall manage it, and we shall make progress then too. That's the whole of the next session will be the medical ethicists. That'll be the Tuesday and the Wednesday, and if necessary, further in that week. I think just the Tuesday and the Wednesday will probably be sufficient.
Yes, that's the plan at the moment.
So, for those of you who are watching online, we sign off now until Tuesday week, the 26th of January. Thank you very much.